The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell from Leading Age Michigan, and we welcome you again this morning to our weekly Wednesday Safe and Calm webinar. We know that our members continue to take care of our most vulnerable seniors, and that as overall caseload is decreasing, we know that it will probably increase for a while at least in our senior communities. So there's still daunting tasks ahead of us, and it's our goal to support you in your efforts to provide a safe environment for both your residents and staff. And we appreciate your dedication to that mission every single day. Today we've moved the agenda around a bit, and we'll spend a short time on situation status. Blake, you can forward the slide, please. Move to advocacy, and then, of course, to the guidelines and directives. The number of announcements over the last couple of days seems to have decreased a little bit, but there have been so many over time that it's still difficult to track all of them together, and some of them are a little conflicting or different. So we will try and help you track these as best you can. Much, again, of what we're going to talk about today is not new, but these small issues keep evolving. And so we'll try to focus on some of those more difficult areas. We're going to start today by looking at the U.S. New cases compared to that of other major countries. While we still lead very much, unfortunately, in the number of new cases every day, and it's measured here using a 7-day rolling average, which I think is a really good way to do it. You can pretty clearly see that we have definitely flattened with a slight downward trend. So there are some good signs happening out there. So I'm not sure exactly where we rank now in terms of comparisons to other states. I think last week we were down to like 6th. At one point we were like number 3. But we do continue to drop in the number of new cases over time. Overall, you can see that we carry about 4% of all the cumulative cases, which doesn't sound really bad, but you've got to remember that New York, still takes the bulk of these cases. And so while our cases are far fewer, we still have a lot compared to other states. And we still have about 3,000 people in the state hospitalized and a little over 1,000 in ICU. These are the numbers that the department posted yesterday. So this graph here is a picture of the daily new cases since April 1st peak. Around April 1 or April 2, we peaked in the number of daily new cases. And you can see the slight downward trend, but you'll also notice that it has an up and down pattern. And if I were just looking at this without knowing what it was, I would say there is some sort of a pattern here. And you'll notice that a lot of these valleys show up on or around the weekend. So I think that a lot of this variation up and down really has to do with how tests are reported rather than the actual caseload changes. Because if you look at the next slide, what I did was I took all of those data points and did a 7-day rolling average. And you'll see that it's much smoother. It kind of eliminates that peak up and down spiking thing that it does. And the really good news is that you can see a definite downward trend happening here. So that's good news. These graphs were published by the department as of April 25th. And I think they're going to report this data now weekly. The top graph shows the overall number of tests. And it includes data from every other day. So it's not every single day that the data is reported. You can see that the number of tests in general are increasing. The orange area is the number of positive tests as a percentage, a number of positive tests, those are raw numbers. And if you compare them to the number of tests done, you can see that that proportion is fewer. So again, this is another sign that we're doing better. If you look at the bottom graphic, this is the cumulative tests and the cumulative positives. And again, you can see that as testing goes up, our positives are going down. Again, really good sign. So this is a graphic from MDHHS that I posted before. And it has changed a little bit over time. You can see some movement to the west in terms of the dark color. It's still pretty much, very much located in the lower part of the Lower Peninsula. But again, if you really look at this, it is very much centered over the metropolitan Detroit Tri-County area. So this week, the governor announced her planning team for reopening the state, and some of the criteria used to determine the speed and the spread for reopening. She has created what she's calling a Michigan Economic Recovery Council, and these are the regions for reporting. There was quite a bit of controversy about this because some of the regions, residents in the lower thumb area did not feel like they should belong in the Tri-County metropolitan Detroit area, in the same area. So there was a bit of a controversy about that. The table to the right simply shows the difference in population in those areas. So this graph was also published by the governor. And it identifies by region how long it's taking the new cases to double. And you can see that pretty much across all the regions, there's a flattening out with a remarkably high number of cases in Region 1. So one of the things that we know that the state's doing is collecting nursing home data. And although there's a lot of gaps in this data, a lot of facilities still aren't reporting. And I looked at the data on Friday and again on Tuesday, and found that there were a lot of rapid shifts, like a facility that had 78 cases on Friday suddenly had 30 some odd cases on Monday. And I'm not sure how accurate this data is quite yet. However, the overall caseload as reported is 2637 across 155 facilities in the state. When we look at Detroit and Wayne alone, we can see that together they hold about almost 30% of all of the cases in nursing homes. But that's covered only in 20% of the facilities with cases. So what that means is that there tends to be a bit more cases in the Detroit and Wayne areas per affected nursing home than elsewhere. And it shows that there's a lot of concentration still in the metropolitan Detroit area. Detroit's doing a lot in terms of testing and getting into nursing homes. We have heard that Wayne is not, and that's part of our discussion with MDHHS right now. So with that, we will move on to advocacy, and I will turn the mic over to Dalton Herbal, who is our Director for Advocacy.
Good morning, everyone, and thank you for joining today's call. I just wanted to remind everyone that we did upload the handouts for this webinar. So you should see a handout tab on the GoToMeeting little toolbar there, and you can download the handouts right now. So that way, if you get interrupted during this presentation, you will still have at least some material to go by, especially because some of my slides today are text heavy, as they include the exact language that some people have been using in terms of some of the programs. So I just wanted to let you know about that. We have 3 main topics today for advocacy. Nursing home, the first one is going to be our nursing home COVID caseload. What is the advocacy we're doing around that? And then a brief discussion about IPRAT teams. Yesterday on the HFAAL Day web call, we had a great speaker who really flushed out some of the detail behind these teams. We're going to do a review of that. Second, we're going to do a review of what the Elder Abuse Task Force is doing, what they accomplished in the first year, and what their second year initiatives were at the beginning of the year pre-COVID. Some stuff has changed, and we'll see in that presentation. And then lastly, we're going to do a brief review of some of the tools that the governor is using for her Michigan Safe Start plan and where we stand today on what is going on with reopening Michigan. So the first thing about advocacy, we've really been advocating for additional clarity for long-term care, healthcare in general. We feel that the executive orders, a lot of the material coming out is not clear and can oftentimes be misleading or up to interpretation, and it leads us to taking missteps or potential missteps. And we've really been advocating for that. And because of that lack of clarity, we are adding some more points to our advocacy points going forward. We'll continue to ask for greater support for long-term care, a greater spotlight for seniors, increase the access to testing equipment and staff support resources from the state and other stakeholders. We'd like to align the COVID return to work criteria that is communicated by local health departments. Members have been finding that local health departments' return to work criteria is not consistent across health departments, which creates a struggle for members who pull their staff from various parts of their community. That's clearly something that needs to be addressed. And then our last advocacy point that we've been talking to people about is that we want to prioritize facilities with high numbers of COVID positive patients when the state decides to deploy those IPRAT resources and the IPRAT resource teams. There is some good news on that point right there. We'll discuss that later when we get into IPRAT teams. So this week, or last week actually, on Friday, we had a call with House Democratic leader Greg and State Representative Donna Lisinski. They are both out of Southeast Michigan, so we thought it would be a good time to discuss with them kind of the problems that we're seeing in resource allocation in Wayne County, and just getting a better spotlight for seniors in places that are hotspots. Kind of a fun fact that was said on the call is that Donna Lisinski recently won the internal party election to become the next House Democratic leader. This does mean she's out of Washtenaw, so any members in Washtenaw may have the Speaker of the House as their representative, so that's exciting. Kind of a couple points she touched on. They're very wary and do believe that the upcoming budget deficit is going to be between $2.5 and $3 billion. And their hope right now is for federal assistance, at least from their perspective. They think that this hole is almost insurmountable with cuts, and they're really hoping for that assistance. She also did comment on long-term care and said that there needs to be a greater spotlight, especially because she's also hearing things that seniors are not being put in the spotlight once again, put in the spotlight in Southeast Michigan in terms of resources. She also says that the governor is constantly thinking about long-term care and the struggles of Michigan seniors. She cited the recent comments made by the governor regarding a $2 increase for in-home care workers as the governor's thinking. So now we're going to move on to IPRAT teams. I just want to give a big shout out to the Leading Age Michigan education team. It was a great day yesterday and a great presentation by Brenda Brennan. She is with the Surveillance for Healthcare Associated and Resistant Pathogens Unit at the Communicable Disease Division. She is a person who helps run and coordinate the IPRAT teams, And this information comes directly from her, so you know that this is some pretty good information. I copied the exact language, so we can see how these operate and what their goals are and what they'll be looking for when they do come in and try to assist you for your COVID-19 dilemmas. Firstly, the goal of the IPRAT team is to prevent COVID-19 from entering long-term care facilities and containing the spread in facilities with positive residents. Who are on these teams? You have a communicable disease division staff member from CDC or MDHHS. You have representatives from LARA. You have a member from PHA's investigation team. That is the team who is doing the contact tracing for the state. And you have a member from the Medical Services Administration. They are collaborating with local health departments to provide training and interpretations on latest guidance documents, review infection prevention policies and procedures, assist with contact tracing, and conduct remote infection prevention and control assessments. And a big factor is that all IPRAT teams are remote at this time. She said that the state just doesn't have the manpower to do these strike teams that will actually visit your buildings, but that is still a goal of theirs. But right now it is remote. So what are they looking at when they come into your building to assist you? They're looking at the following elements. They're looking at your visitor restriction policies. They're looking at your education monitoring and screening for healthcare personnel and those same, the education monitoring and screening for your residents. They're looking at your availability of PPE and other supplies. They are looking at your infection prevention and control practices and policies. And they'll be looking at your communication with health departments and other healthcare facilities in your general area to see how you're coordinating your efforts to combat COVID-19. The findings that can come from it can target specific infection control preparedness activities that nursing homes can immediately implement. They did stress, actually, that the main activity of these units is to provide guidance, interpretation, and recommendations to your facility. And then the considerations for who will be receiving these IPRAT teams and these resources that they bring with them will be determined by the EM resource or MDSS data that is submitted to the state. They will be then coordinating efforts around that. She did also mention that referrals from local health departments will also be taken into consideration, so that's just another thing to think of moving forward. So what are the resources that these teams can provide? They'll be working with you on your public health response, screening of residents, staff, visitors, staff working while ill, just general policy help. They'll provide you with sample letters that you can use for notifying families and residents. They'll provide presentations on best practices. They will create, or they'll hook you up with the long-term care respiratory surveillance line list. And they'll be coordinating and helping you to coordinate local health department resources. And lastly, this is how the structure of the IPRAT team will work. On the top, you can see where they'll be receiving the information, and then it goes down to what their plan will be to assist you. So for a proactive approach, you'll see that the facilities will be chosen via the data that's submitted and then logged into this IPRAT tracker, which is essentially a ticket system if you're familiar with those. And then a referral from a local health department or a partner or follow up from a regional hub will go to their inbox and then into their tracker or ticket system. Next step for them will be to contact the local health department and assess the next steps. Right now, they'll be going to the remote IPRAT team. In the future, they'd like to have an on-site strike team, and that's still a policy goal for them, but that's not available right now. And then once that remote team contacts you, they'll review your infection prevention policies and procedures, the guidance, and provide you with a tele-ICAR. The ICAR is a testing thing that they developed for Ebola that they have since shifted to COVID-19. So they'll help you determine where you're at in your COVID-19 response. Lastly, we do need your help. If you do get contact from an IPRAT team, we're trying to track exactly what they're doing, exactly what's going on, because it's one thing to say one thing and then they can go on and do another, as I'm sure many of us in healthcare are aware. If you do have experience working with an IPRAT team, please let me or Laura Funch know. I posted our emails right here on the slide for you, and that we'd greatly appreciate it. So secondly, I want to provide an update on the Elder Abuse Task Force really quickly. So just some background. The Attorney General set up this task force including 30 different organizations. They include law enforcement, state agencies, Michigan House, Senate, and congressional delegations representing both sides of the political spectrum, the Supreme Court, and many advocacy groups. Leading Age Michigan and Leading Age Michigan members are involved in the task force and on various subcommittees on the task force working on many issues. Most importantly, we're on the legislative subcommittee, so we get to see any kind of legislation that comes through the task force before it's released and considered by lawmakers. During the first year, the task force initiatives focused on guardianship, conservatorship, and financial exploitation. We'll see that on the next slide on what they accomplished during year one. So during year one, the Elder Abuse Task Force created a elder abuse bill package. This expands the definition of what is elder abuse and amends penalties, and etc. That is currently in the Senate Judiciary and Public Safety Committee and has already passed the House. So if there's any act that does have legs coming from this, it's that first one right there. Senate Bill 464 and 465 creates the Financial Exploitation Prevention Act. This requires financial institutions to report elder abuse and train their staff in recognizing elder abuse. And that is also currently in a Senate committee, but it has not passed the House, so it's still early days for that. Senate Bill 798 would amend the visitation rights for legally incapacitated individuals, and that is still also in a Senate committee and has not passed the House, so it's still early days for that, even though these bills were introduced last year. They also hired 3 more full-time prosecutors to help process elder abuse claims in the Attorney General's office. They created training videos and standard reporting documents for law enforcement, and they conducted a statewide listening tour in which the Attorney General and other policymakers went around the state and listened to community feedback. Things have changed since then. The last meeting was in February, where we got the upcoming year 2 initiatives, but we're currently facing a massive budget deficit. The Attorney General's office has laid off 100 workers last week, which is about 25% of their total staff. So it's still kind of unknown as to what the horsepower of the Attorney General's office is right now, but we are going to present on these upcoming initiatives as if they're still the same. I imagine they would largely remain the same, except for maybe some of the ones around funding. So these next couple slides are just the policy initiatives. I'm not going to read them all to you. Feel free to. I'm just going to highlight some of the key ones that we're actively involved in, just by proxy of our members being involved and us being involved in committee in general. We do have say on every single one of these, but some of these we're really getting into the detail on. The first ones I want to point out on this slide include the revising of the Consumer Protection Statute to include criminal penalties for violations involving victims over 80 and increasing civil penalties. We are involved in that one. And then one we're heavily involved in, we're on the subcommittee of the subcommittee for this one, increased CENA staffing requirements and reviewing nursing staffing requirements and creating liability for owners for negligence, gross negligence, and supervising staff. Our goal with this one is to hold more people accountable for elder abuse and increase staffing requirements. So we are definitely heavily involved in that one. These are 5 more. A couple I want to highlight. The first one is increasing adult protective services staffing and updating on the reporting mechanism. Increasing staffing is going to be a hard ask right now. So it's just something we want to highlight. And then there should be one, I must have missed it on the last slide. They're looking at revising the definitions for all of long-term care and all of long-term care entities, including assisted living and HFA and everything. What they're really trying to do is provide a legal structure for people to be able to determine what is what in Michigan. And they feel right now people can advertise that they have an independent living, even though it has different services than the independent living next door. So that is something they're looking into. And I think that is it for this slide. That is also something we're really heavily involved, looking at those definitions. We're also on the subcommittee for the subcommittee on that one. And then ultimately anything they do has to go through the legislative subcommittee, which we're also on. So we'll have a lot of say and a lot of impact on that. So lastly, I want to touch on the governor's Michigan Safe Start plan, which is her plan to re-energize and reinvigorate Michigan's economy. As you can see, I included the map that Deanna spoke to earlier regarding the regional approach and the phased-in approach that the governor plans to take. And the next slides will introduce us to some of the tools she's looking at and planning to use in the go forward. This first slide is the framework that she's using to make, she's making and encourages others to make or to use for making return to work decisions. On the left, you can see we have pandemic risk. On the bottom, we have workplace risk. So you find yourself where you are on the category. Right now, she believes the pandemic risk is urgent, but slowly moving into stabilizing. So you can kind of, I mean, it's a tool. You can figure out where you are on it and move from there. So what does she feel the specific risks boil down to in Michigan? Those three things are worker interaction, workplace characteristics, and workplace or worker type. So who are your workers, where are they working, and what do they do? And how does that impact their risk of transmitting the disease? As you can see, interaction with the general public is a key factor. Contacting with fellow coworkers, do they share tools or equipment? Do they work inside or outside? How many workers do you have? How tightly do they work? Is there travel required? What's your basic industrial hygiene practices? What are your demographics, pre-existing conditions, contacts outside of work, transit options, and immunity for your workers? These are all things she's considering very highly when looking at forming her plan. So this is kind of an intro to the next slide where she's going to be providing guidance on to what each labor force type should be doing, looking into it as far as protecting their workers. She breaks it down into 9 categories of workforce and worker types. Just for reference, we can move on to the next slide. So I'm not going to read all these because it's a lot and I've already gone pretty long here, but these are the best practices that have been developed for the 9 workplace types. And you can see that they fall into 5 categories: access and control, social distancing practices, sanitation and hygiene, your PPE resources, and your contact tracing and isolation practices. These are all things to consider when moving on, looking to reopen your workplace. So where are we today? Right now, there's no set timeline, and the governor plans to follow the medical data in setting forth her timelines, which is good news because our cases are trending downward. And I just found out this morning that construction and outdoor jobs are likely to reopen on May 7th. You may have seen a lot of lawn care workers out this week. I think that's a good sign if you went for a walk yesterday or during one of our nice days so far. So far, she has received a lot of political blowback from this in Lansing. Last Friday was a bit of a doozy in terms of the Michigan legislature. They held a special session to form an oversight committee to oversee the state's COVID-19 response. And that resulted in pointed attacks from legislators against one another and them all putting bills up that either bolstered or stripped the governor of executive powers from the respective political parties. So Democrats wanted to bolster her powers and Republicans wanted to strip her of powers, and there's often bills out there, or there are bills out there, that say the same thing but in opposite directions and have opposite intent. So right now, where we stand is the state of emergency is set to end April 30th, and the governor has asked for a 28-day extension. Legislative Republicans are thinking they want an 8 to 9 day extension of that Emergency Act. While this is a debate going on, we do believe that it will get extended. The only thing that's at risk is if they don't get this done in time. The governor believes that if she has to act alone, which she does have the power to do so, she can extend it all by herself without legislative permission. But if she doesn't, that would remove the protections from liability for emergency/disaster relief workers. And that is would be disastrous for us in the healthcare community, as many of us are designated as emergency and disaster relief workers. Right now, they believe they're getting something done. They have been in talks, nonstop talks, for over 2 days now. So I believe they'll get something done. They should get something done, but we'll continue to advocate for them to get something done. And with that, I'd like to address any questions that we may have.
All right. Are the IPRAT teams only looking at nursing homes?
No, they're not.
Okay.
But obviously not everyone has to report through that EM resources portal, but they are moving on what local health departments have to say. So if you do make a report to a local health department, that is something they will consider.
All right. This says, is there any dates given when they will implement HFA, AFC, and assisted living?
I haven't seen any dates. I don't know if you have, Deanna, but I have not seen any as of yet. I know they do plan.
For the IPRAT teams, so we're talking about specifically for the IPRAT teams, my understanding is that it's a possibility that they will move into assisted living type areas, but their focus right now is on nursing homes.
Barb said, I think they are asking about EM resources.
I haven't seen a date for that either yet.
Okay.
EM resources for AFCs and HFAs. We have no date or no clarification yet coming from the department.
Okay. And then I think that these questions will be more towards Deanna, but when you refer to testing, are you talking about nasal swab tests?
Oh, I'm not sure how to answer that. The testing in response to which piece? Something that Dalton was saying? Or
No, I believe
when we were talking about, those were, I think that those are primarily nasal tests. I don't know that they're 100% nasal tests. I don't know if the state health department distinguishes that even. That's something we'd have to look into.
All right. And then what are the thoughts on the IgG and IgM tests?
I don't have any information about that. I do know that we have, the department has reached out to us to talk about some of the barriers to getting nursing home residents tested. And we will be working closely with the department in order to figure some of those issues out. In terms of individual kinds of tests, we would have, and their efficacy, if that's what the question is about, we'd have to refer you to another expert.
All right. Are homes for the aged required to report supplies? And if so, how do we gain access to the EM resource database?
Okay, this is something I'm going to discuss in a little bit, but at this point, AFCs and HFAs are not required to report PPE. However, the latest directive from the state says you should be preparing to do so. So you should know what your PPE status is every day, but there's no reporting requirement at this time.
Okay. I don't see any other questions. Someone did say that they looks like they're having trouble opening the handouts link. So I don't know if anyone else is having that issue as well. If they are, we can go ahead and make sure that we just send the PowerPoint along with the recording and everything as well in the next couple days.
Okay, actually, I plan to speak to that in the next slide and section. We're having a hard time, at least I am, making the links live, even though I try to make them live in the PowerPoint. So what I'm going to do is we're going to put all of the links in the Word document Q&A that comes out later.
Sounds good. And then it looks like someone else had said they didn't have any trouble opening it, so maybe give it another shot and hopefully you can get through. No other questions, so we will go ahead and move on now.
Okay, so we're going to move into guidelines and directives as we usually do. And we're going to start this morning with the Governor's Executive Order 2020-50. Now we know that it's been a couple weeks since that's come out. And if you remember, this was the order that initially set up some guidance that covered all long-term care settings in Michigan, pretty much except for independent living. It included unlicensed settings in the beginning. I think the department has finally pushed back on, gotten the message at least, that considering that there's no definition for assisted living outside of AFCs and HFAs in Michigan, it doesn't really make a whole lot of sense. So they've kind of taken a step backward from that idea. Several of the provisions, when we first reviewed it, seemed really hard, in my mind at least, to operationalize. And I think that it's something that we could have anticipated, that the department had to take a step back. And they took a lot of step backs and changed kind of pretty much the whole feel of this executive order when they did so. But we're going to review again some of the pieces, the larger pieces that's in this order, and call out some of them that continue to be problematic or that we continue to get questions about. So basically, the first bullet that I have here is that facilities may not insist on testing before admission. That is something that has been placed in CMS guidance, CDC guidance, and Michigan Department guidance, both on the LAURA side and MDHHS. And the reason for this, and I know that this challenges members and providers considerably, but the reason is that the state has a really big fear of holding back discharges from the hospitals and trying to keep those hospitals able to take care of any surge that might happen, and this was their fear. So the CDC does prefer testing before someone is considered non-infectious anymore, but they do not require it. And they have a lot of conditional scenarios that you have to go through in order to determine how safe someone is and what the protocol should be for them. We're going to talk about this a little bit more later. Another really problematic area was there was this whole section on that you have to allow any previous residents to return just as if they were just discharged from the hospital, returning to you, or coming back from therapeutic leave. There were a whole lot of people, such as AMA residents, et cetera, that some providers thought was inappropriate. They haven't really spoken to this again recently. I think that they did get the message that this is a hard piece. They don't seem to be moving forward, but we do not have any clarification that this doesn't apply right now. So technically right now, this piece is still live. Must foster telemedicine. We did put out 2 tools that were developed by Dyke and McGossett. We will redo those links because they want to make sure that you're limiting very much the number of healthcare professionals moving in and out of these facilities. And this applies to adult foster care and HFAs as well. So we will, again, provide the links to those tools because you have to demonstrate a best effort toward providing telemedicine. Maintaining normal social distancing and infection control precautions. There's a whole section in there about that. There's really not a whole lot new there. Must inform employees within 12 hours of COVID-affected resident. In other words, if you identify a COVID-affected resident, you are required to inform that employee within 12 hours. There's a lot of reporting changes that came out after this order, but this has not been changed. So you still must inform employees if you identify a COVID-affected or suspected person. A COVID-affected resident needs to be communicated to the staff. And you are required to notify all your staff of CDC updates. So facilities are told to keep accurate PPE data. And I put the iffy things, depending on which kind of provider you are, in green here. So all facilities, HFAs, AFCs, nursing homes, are supposed to keep accurate PPE data. And in the EO, they were supposed to report it to MDHHS. We do know now that there is no reporting going to MDHHS from any other entity other than nursing homes in terms of senior care. So you must report your cases also to MDHHS. And again, that at this point only applies to nursing homes. However, the EO says you do have to report your cases to local health departments within 24 hours, and that applies to all three of those provider types. And again, of course, you must transfer medically unstable to a hospital. I think that's self-evident. So notice that these pieces are all green. These pieces are all on hold. The idea that nursing homes have to create a dedicated unit, if less than 80% occupancy, that's all on hold. Medically stable have to be moved to a dedicated unit. That's all on hold. They're supposed to identify what a dedicated unit is and put out some guidance, but I don't think that they really completed the guidance yet for what a regional hub is. So I think that that's going to take a while for them. And again, these are the pieces in terms of the priority placement coming out of any kind of setting where they should go if there's no dedicated unit. And again, all of that on hold. So you must communicate advanced directives to any person that, any facility or place that someone's transferred to. That's kind of self-evident. Must admit anyone you would normally admit, even if coming from a hospital treating COVID. And again, that's part of that testing piece. Notifying residents of transfers ASAP. You do have the ability to transfer. All levels of providers have the ability to transfer someone for their health and safety if you don't have the ability to adequately serve them. But that only applies to COVID positive patients, that you do have to notify everyone, but you don't have to do it before you transfer them if you don't have time. So, and that kind of goes along with the fact that bed holds and pre-transfer and pre-discharge requirements, it says suspected. I'm sorry, I typed fast. It's supposed to be suspended. Those pieces are still suspended, and they were suspended in the 1135 waivers and through all the CMS and MDHHS documents as well. So then following putting out the Executive Order 2020-50, which was only effective through May 13th to begin with, they narrowed the settings and are allowing these regional hubs really much to focus on transfers from hospitals and other nursing homes, which I'll be honest with you, I was very concerned about, because I'm concerned about the ability of some AFCs and HFAs to keep residents safe. I'm not sure that they were all designed to do that. It does reiterate that you have to report all entities, COVID-affected persons, to the local health department in 24 hours. You must continue to transfer medically unstable to the hospital unless there's an advance directive otherwise. They added that piece there because people were saying, well, why are we going to transfer someone who doesn't want to go to the hospital to the hospital? And then additionally, only nursing homes are reporting now. IPRAT teams are coming out mostly for remote engagement in the beginning at least. And they keep telling us there's an updated hub guidance forthcoming and a guidance for these dedicated units and transfers coming later. And we have yet to see the detailed hub guidance, at least, in either of those others. So then following that, the department issued an L letter. An L letter is a special letter to a specific set of providers. SNFs, it talked about the data elements for SNF reporting, including caseload, PE, EM resource. The reporting period is daily, a 24-hour period going from midnight to midnight that had to be reported by the following noon. And that includes weekend times and holidays. You have to report every single day. If you don't have access to EM resource, then I would assume that there are some facilities out there that do not yet, because I don't see reporting from all nursing facilities in Michigan at this time. Access should be made by contacting your regional healthcare coalition. They're the ones that will get you access into that. Then at the end of this update, that was signed by Kate Massey, who is the Medicaid director. And I put this in quotes because I copied it verbatim. As a reminder, CMS mandates that nursing facilities inform residents and their representatives within 12 hours of the occurrence of a single infection of COVID-19 or 3 or more residents or staff with new onset respiratory symptoms that occur within a 72-hour period. Well, at this point, you are supposed to collect that data. There is a previous CMS guidance that says you have to collect this data, and I'm not sure that most members are aware of that, at least for nursing homes. But the reporting to their residents and representatives, according to the CMS QSO 2026, pretty much says, well, we're going to give you guidance to do this, where it implies that you're not required to do it now, although you're supposed to collect this data. And you're supposed to be reporting it to your local health department according to that guidance. You don't have to inform residents and the representatives, and you don't have to report to MDHHS at this point. So this is something that we need to clarify with the department about what their intention is here, because CMS isn't mandating that. So I think maybe I have gone back and reread this, I don't know how many times, but the paragraph in QSO 2026 specifically says we will providing guidance to do this, but they haven't yet. So in the last week, the Paycheck Protection Program and Healthcare Enforcement Act was passed and signed by the president. This includes small business loans, additional grant monies for healthcare, and it also establishes some reporting requirements for these grants, and again, more money for small business programs. There's been a lot of pushback from the feds about the appropriateness of some people getting small business loans and getting some of these grants, although technically they qualified for them. And so we have heard, I think for a couple days in the media, that they're going to be auditing a lot of these grants and loans and how the money's being used. So I don't have a whole lot more detail about this new law yet, but we are working on that as we speak. What I have provided today, and again, these links don't work. I can tell you that. I put them in there. I did it several times. I can't get the links to work myself. So these links are going to also be included in our Q&A. But there's a fact sheet about this new law, a summary of it overall, and how to apply. And we'll be getting that out to you. So a little bit about AFCs and HFAs. As part of my personal concern and dilemma is that, you know, we don't have a consistent set of rules across these provider types in areas that it would seem that the issues would be the same. This is a direct quote from Jay Caseload from the Bureau. And it's pretty much clear that the Bureau is really kind of deferring, or maybe they have to defer, to the department to issue orders and directives to implement 2020-50 that we talked about. So the director has issued an order that provides some guidance, but additional guidance is being developed. So anything about AFCs and HFAs other than what we talked about before is kind of up in the air. I do hope the department gets a little bit clearer about how to address some of their issues, and we continue to talk to them about that. So there is a frequently asked questions document that was updated on 4/21. It is on the website. We can give you, it is also on our website, but we can give you a link to it. And it talks about fingerprinting, which has been very confusing throughout all of the emergency period. As of 4/21, they said the fingerprinting is still required by law for AFCs, HFAs, must be waived by the governor. Pretty much one of her executive orders said that that Laura can suspend it if there's not enough locations, and at that point 43 locations were still open, and that if you couldn't get someone fingerprinted, you can still offer conditional employment, but at that point you need to be fingerprinted within 10 days of your start date regardless. So with the Executive Order 2020-61, and this was language that, I'll be honest with you, I had a hard time interpreting, but we've gotten clarification from both Larry Horvath and Jay Caseload that allows AFCs and HFAs to postpone fingerprinting just as a nursing facility can until 10 business days after the end of the state of emergency. However, if you don't get the fingerprinting done, you have to do an ICHAT. And they are anticipating putting out more guidance about everything else you might need to do, because they're going to probably allow you to do a conditional employment, but there are probably some other requirements you're going to have to meet. However, at this point, they have not done that, and so the rule is that you can postpone as long as you do an ICHAT. So some other things that keep coming up for AFCs and HFAs, inspections, just like nursing home surveys, are still on hold, except for serious issues. And license extension letters will be sent as long as you file your renewal application. So make sure that you know that that hasn't been suspended. The Executive Order 2020-59 requires any kind of business to provide face coverings for their employees, and that would include healthcare providers as well, AFCs and HFAs. Again, there is a requirement that you do notify, even though you don't have to report now, you do have to notify employees of COVID cases within 12 hours. And the dedicated unit piece, as it applies to AFCs and HFAs, is completely up in the air. So additionally, we anticipate that visitation, although it is only current through May 3rd, is probably going to be extended. We do know that although the case numbers are going down, we're sure that the issues in senior care facilities are still paramount. We get a lot of questions about the direct care worker pay, and we've received some clarification about this, because in the beginning I really did think it was only for in-home services the way it was written. However, it is for any personal care provided through specific Medicaid programs, adult home health, which does fund some care in some homes for the aged and adult foster care. My Choice, again, funds in some residential settings, My Health Link, and behavioral health within behavioral health homes, and for in-home behavioral health visits. However, it's easy to identify Medicaid funding for personal care for an in-home patient in My Choice. It's not easy to figure out how the department is supposed to pay this additional amount directly to a direct care worker for these 3 months if that person's taking care of 10 patients and only 2 of them are Medicaid. So the department has noted that that's not going to be easy. They are working on some sort of guidance, but we have not seen anything yet. AFCs and HFAs do have the ability to quarantine people for symptoms or if they have a positive diagnosis. It's not a violation of resident rights. You do need to have policies and procedures that speak to that. But obviously, this is a issue that is for health and safety, and you have the ability to do that. You can make an admission requirement to quarantine a person if you don't know their COVID status or that if they have symptoms. The idea is, though, that you should make an admissions requirement. It should be in your admission contract, and you should let all of your people know as they come in that may well need to happen. So briefly about QSO 2028, and this is specific to nursing homes. The first part of that letter is about inspections. Inspections that occurred on or after March 4 are going to be posted on the website on the front page, but they're not included in the star rating calculations because the inspections have been sporadic and not done routinely, so it's not really fair to have your star rating affected by that. These new star ratings are coming out today on Nursing Home Compare. PBJ delays and the quality measures, they're going to be reported as they currently are. Even though there was a delay in reporting your staffing data for a couple months, the information today is all from a period before that delay happened, and so they're going to report those 2 areas as they normally do. But that could change later if they don't have full sets of data down the road. Then they put this long document in this letter for frequently asked questions. And I really felt that most of them, I think that we've worked out over time. There are 3 basic areas that they refer, and these were actually links, which I will send out with the Q&A. But these are the primary areas that they're focusing on for these frequently asked questions. So the first area is testing. Again, there's just so much about testing and people's reluctance or facilities' reluctance, and it's understandable. If you don't have any COVID patients in your facility, we can see why people might be reluctant to bring an infection into their facility. However, the focus really is for pretty much all the regulatory entities to make sure that there is hospital capacity and that they believe that it's safe to move people to downstream providers without testing. Although the CDC will say they prefer residents to be tested, but it's not required to do so. So you're not supposed to really, I'm sorry, go back. Blake, thank you. So you're really not supposed to look at a test in order to make a determination whether or not you can admit someone. You're supposed to be looking at their clinical status, whether or not you can meet their individual needs, and whether or not you can meet whatever infection control requirements might be needed. If you cannot discontinue transmission-based precautions, in other words, a person doesn't meet the CDC criteria for that, they must be transferred to a facility who can do that and in a designated unit. So there is the option to make sure that the hospital works with you to make sure that this is a safe transfer and that you have the ability to meet their needs. If the person meets the criteria for discontinuing but still has symptoms, you are supposed to provide an observation room for them, make sure they wear a mask, and continue to make sure that no one is coming in contact with them, because they meet the criteria to decrease the precautions, but they're still having symptoms, and that's a concern. If someone meets the criteria for discontinuing those precautions, has no symptoms, then there are no restrictions about where they can go. They can go in the general population. Residents with an unknown COVID status, though, should be placed in precautions in an observation area or private room. Not necessarily in a COVID unit, though, because if they don't have COVID, you don't want to give it to them. So you need to have some sort of area or private room for your observation patients. And again, the CDC requires that all of these scenarios be considered before making a decision, but people do not have to be absolutely tested. So the next piece is about staying connected, and I'm not going to go through this list. I mean, I think most of these things everyone knows how to support communications with family and residents. There is a CDC sample letter to help inform residents about where you are. Again, that's something that we'll get you a link to. And they also encourage facilities to apply for CMP funds to assist with some of your electronic resources. You have to put through a formal request. This is a formal CMP process. There are some additional rules for COVID patients that you can only get $3,000 maximum per facility for such things. But if you need to get, some sort of computer thing that allows you to do videos, etc., you do have the ability to do that. And we will, I think we put in an update the other day who to contact at the state, but I will include that in the Q&A as well. End of life care. This is an area where I thought that we pretty much had this down, but then the Bureau over at Laura kind of threw a boomerang into it. Pretty much CMS for nursing homes has said that you really need to look at all of this on a case-by-case basis, whether or not you allow and when you allow visitation for persons at end of life. They encourage that decision to be made with the resident's family and clinical staff. And they pretty much point to the idea that just because you're hospice doesn't mean that you have sharply declining health status. And if you're not hospice, you could still have sharply declining health status. So those are things to consider when you think about that, because the idea is that you really need to limit any external visits to those that are absolutely necessary. So it's still really important to make sure that you control who's coming in and out of your building. And no one with signs of respiratory infection should ever be allowed to enter, no matter what. However, Laura is telling us that pretty much anyone on hospice meets that criteria for AFCs and HFAs. But facilities still need to ensure safety. Some limitations may be appropriate. You can make a determination about how many people can visit, how often they can visit. They still have to make sure that there's appropriate PPE if you have COVID in your facility, and that you're taking all the necessary social distancing precautions regardless. So you do have some ability to make decisions on a case-by-case basis if you're an AFC or HFA, but Laura pretty much says anyone in hospice falls in that category. So that's a little bit of difference between what CMS is saying and what Laura's saying for HFAs and AFCs. So they discourage also leaving against medical advice, but you can't legally stop someone from leaving your facility. And if you do so, though, you are required to make sure that they understand the risks, the precautions, etc., before they leave. Healthcare workers, there's a lot of questions about which healthcare workers should come in to a facility from the outside. So you are required to screen healthcare workers. A lot of facilities have kind of not liked the fact that EMTs don't necessarily go through the screening process all the time. However, all levels of guidance from the state, the CDC, and the feds pretty much say that EMTs are screened once at the beginning of a shift, and then they screen each other once during the shift. And so the idea is that in an emergency setting, you shouldn't be stopping EMTs for screening as they come in. Healthcare workers, in order to determine whether or not or what they're doing is essential and absolutely necessary for your consumers, again, it's a case-by-case basis. Evaluate the resident needs and what services are needed to determine whether or not they're essential. Encourage telemedicine as much as you can. It really needs to be something that cannot wait in order to let external healthcare workers in. Residents should be discouraged from leaving the building unless absolutely required, although you can't stop them. And if they are needed, please, take the precautions, make sure they have PPE as needed, make sure they have masks. The trick is, if someone goes out to an appointment, when they come back, CMS says in this QSO that you have to monitor for 14 days and preferably in an observation space. So that's a lot of work for someone to go out for a 1-hour appointment. And again, therefore, they encourage telehealth. Cohorting, I don't think there's anything really new here about cohorting. Every facility that plans to take care of COVID positive patients or has COVID positive patients needs to have a plan and a design for that. Communal dining, again, the ban on communal dining does not mean that people cannot eat in the dining room. That means that they have to have social distancing at that point. No one with signs and symptoms of respiratory illness should be in the dining room. Anyone who you suspect but doesn't have a confirmed diagnosis should be in the dining room. Surveys, we just heard from the Bureau through Larry Horvath a couple days ago that CMS is going to restart their outreach services to nursing homes very shortly. We don't know what that means, what that's going to look like, but if we get further guidance, we'll let you know. We anticipate that they will continue to focus just on IJs and infection control surveys through the emergency period. They are encouraging everyone, even though that self-assessment is optional, they encourage everyone to do it, and the surveyor may well ask you for it, and they have the right to ask you for it. The other thing is that CMS has encouraged residents to ask if the facility has completed their survey. So pretty much looks like, even though technically it's optional, it's something you need to do. And of course, they're going to be looking at surveillance plans. So I would be, if you haven't reviewed your surveillance plan recently, I would certainly suggest that. Okay, last piece. We have gotten a couple of member questions that we haven't been able to provide resources for facilities looking for acuity tools to support their staffing. And also looking for N95 respirator policies. We do have access to guidance about all of that, but we don't have any member policies that are floating around for either of these two pieces. So if indeed you have something you would like to share, please send it to us either at one of our email addresses or safeandcalm at leadingagemi.org. The last one was a good question I think that we got. I'm sorry, go back. Thank you. The last one is about nursing home administrators. And if you notice in a previous executive order, we noted that a lot of healthcare professionals can assume their roles if they haven't taken their final test. And so that final test has been waived. However, that is only for people who are providing direct care to patients or residents. So nursing home administrators who are waiting for licensure do not fall in that category. Okay, so that does end all of the content that I have, at least for today. What questions do we have?
All right. 1 second. Let me get to the top of these really quick. Do you have to inform regarding COVID-affected residents if the resident is out and at the hospital?
I would say, now, remember that I do not see anything in writing about this, but I would assume so. I would very much want to make sure that, remember that the incubation period can be up to 14 days. So if you sent one to the hospital and it has been, the diagnosis is less than a 14-day period since they've been in your facility, I definitely would think that would fall into the need to report.
All right. Does the 12-hour employee notification requirement include if a resident was tested or only if the test came back positive?
I believe it's COVID affected. So it's anyone that you suspect or has a positive case.
Okay. Is there any update on the specific reporting guidelines to the CDC? The guidance was supposed to be out more than a week ago.
I'll be honest with you, I'm not sure that it was supposed to be out a week ago, but that might have eluded me. But the answer is no. I've not seen anything from the CDC or any other of our contacts that says that it's coming soon. I think that they're working on which elements of reporting that they want, but that's just my understanding to date.
Okay. My LHD has said I should not report 24 hours and is calling me 2 times a week. Do you recommend other action?
I'm not sure if you're a nursing home or a AFC HFA, but I would, we can forward that question to the appropriate department. I always worry about the fact, and we've had this issue come up at other times where, before COVID, where a reporting entity would tell us, we don't want to hear all of this every day that comes forward, and yet we have a requirement to do it. So it's kind of an individual decision. I would probably err on the side of reporting whether they want or not, and then go ahead and have your every two times a week reporting as well if necessary. But it's really hard to say because it puts you between a hard place. I do know that in an outside of COVID, that when we talked about reporting requirements, that someone did get cited for not reporting, even though the people that were being reported to didn't care or didn't want that data. So I would suggest you try to apply the letter of the law.
They are an HFA as well, just so you know.
We can try and get some guidance from the Bureau, but at this point, I would apply the rules.
All right. Our local health department started requesting this updated information last week, and now MSP is calling and asking for information. Were you aware of this?
No, although it doesn't surprise me because I'm assuming MSP is the Michigan State Police. They really are in charge of an awful lot of the pieces for COVID management. So it doesn't surprise me.
All right. Did LMI issue info on NextGen regarding testing? If yes, can you please resend?
We did. It's been maybe a week or two, but we can resend that, definitely.
All right. Will the DCW $2 per hour extra pay for all staff in a building regardless of whether that building has 1% Medicaid residents or 99% Medicaid residents, any proportion bases on relative Medicaid occupancy?
I don't know how the department's going to do this, but I pretty much am sure that they really are going to provide that money only for personal care that's related to your Medicaid patients or residents. So, I think that that's part of the dilemma in these residential settings where everyone is not Medicaid. I don't know how they're going to do it. I would anticipate that you're probably not going to get, that amount of money for all of your nurse aides if you don't have 100% Medicaid occupancy. That's all that I can think right now. However, I've been surprised in the past, so you never know, but I anticipate that they're going to figure out some formula.
All right. CDC added new signs and symptoms of COVID to their website. Are we supposed to add these new symptoms to our screening tool?
I don't remember specific guidance to do that. It would make sense to do that. You certainly would not be restricted from doing that. But I will look at that guidance and figure out a better answer based on that piece in the Q&A.
All right. Someone said that it was a great webinar today, a lot of information, and will you remind us where we can listen again? We will be sending a recording of this along with the Q&A document, I would assume, over the next couple days or something like that.
Great.
All right. And then someone also said they would like to thank you, Deanna, and the entire Leading Age Michigan team for everything they've been doing during this difficult time, and thank you. Thank you. So thank you very much for that. Appreciate that. And then this is the last question I have so far. Regarding communal dining, we interpreted this as no communal dining even with social distancing in 2020-50. Do you think the same is true for programming permitted with social distancing? We have been keeping everyone in their apartments.
I do believe that if you're talking about apartments, you're talking about AFCs, HFAs. My understanding is that there is guidance expected from the Bureau regarding some parameters around that. So I do believe that at this point that is their interpretation as well, that communal dining in those areas is not allowed. However, CMS and nursing homes are allowing it with social distancing as we discussed. So hopefully we'll get some better guidance. It would be nice to get clear guidance more quickly, but unfortunately that isn't always the case.
All right, it looks like that was the last question, so we should be good.
Great, thank you everybody. Stay safe, and Blake, I'm sorry if I cut you off, you can continue, but have a good day.
I was just going to say thank you to Deanna, thank you to Dalton, and then thank you to just all of our business partners, all of our members. We know how much everything is going on right now. We know how difficult these situations are. So this thank you again for everything that you have been doing. I believe we topped out at around 90 attendees today, so that is great. Thank you for everyone who came out, and have a great rest of your day.